So, good morning, friends. Thank you for Chairman. And I express my sincere appreciation to Professor Hamilton. And I will talk focusing on multidisciplinary management for advanced hepatocellular carcinoma. So I'm old, more than 70 years old, and my career, the management of hepatocellular carcinoma is over 40 years. And so during 40 years experience, I got some success with not small failure. So it is very much appreciated if you enjoy my the experience of management of advanced hepatocellular carcinoma. So I will start my talk. I have no conflict to declare in my presentation. In 1990s, in Japan, many hepatocellular carcinoma patients were diagnosed at an advanced stage. At the time, I devised a treatment method in which cytotoxic antidrug cisplatin and 5-FU were directly infused into the hepatic artery through a catheter placed in the hepatic artery. And in some cases, good results were obtained. So as a result, a complete remission, it looks like a complete remission, was achieved in 9 patients, and this was reported in Cancer in 1997. So the hepatic arterial infusion chemotherapy, so-called HIC, is used to treat such advanced HCC using an enduring catheter into the hepatic artery and connecting the other end to a port implanted subcutaneously in the thigh. And then the chemo drug was infused. The protocol is by administrating small amount of cisplatin, small amount of cisplatin oh, sorry. And a small dose of drug, cisplatin, with 5-FU, and repeatedly, and 5 days a week. And we were able to achieve the maximize the therapeutic effect while minimizing side effect. So let me see this case. So in this case, the complete remission was achieved. It looks like a complete remission because of tumor staining in the liver disappeared after the infusion chemotherapy. The tumor staining in the liver disappeared, and the alpha-fetoprotein level is also declined. And the patient was discharged from the hospital. However, the disease recurred after 5 years later, and the patient died 7 years later. So, and I checked these 9 cases in the prognosis in clinical course. So you can see here in this slide, in these 9 cases, where the tumor staining has disappeared, And the complete remission by modified RECIST, I mean that the tumor staining in the liver, was deemed to have been achieved. However, the sequence of subsequent HCC recurrence was, as shown, indicated by yellow arrow. In 8 cases occurred in the liver. From these results, and I learned that even if complete remission is thought to have achieved, but the main tumor in the liver should be removed from the liver. So, in 2000, I moved to a new university hospital as the director of hepatology and liver cancer unit. So at that time, the conversion therapy has been actively incorporated into the treatment of liver cancer patients. And the number of patients undergoing liver resection has increased. And I will now introduce this result of our experience for 13 years. And this result is the data presented at the upper meeting, expert consensus meeting in 2014 in Singapore. So during the 13 years, we treated 723 patients with HCC during 2000 to 2012 at the new hospital. And among them, the 55 patients of advanced HCC were selected in the study following criteria. So you can see here that this criteria is a child pool A and B7, and it means that a good liver function, and the tumor stage is a UICC 7 stage 3. It means that more than 5 centimeter nodule in the liver with multiple and or vascular invasion and or other bile duct invasion or so. So you can see here that these 55 cases, patients of advanced HCC were selected in the study following this criteria. And with good liver preserve, advanced HCC stage, the UICC 3A and B were studied. And this study was retrospectively analyzed. So this table shows that the 50 case, the factor of these 55 cases. So you can see here that average tumor size is 96, and alpha fetoprotein in half of cases over 400. And so on the treatment allocation is, you can see here that the firstly, upfront surgery to 4 cases in 2001 year, and the other 51 cases allocated to neoadjuvant chemotherapy, and then the downstage case is goes to liver resection. So let me see that the detail of our selection. So you can see here that the 4 case goes to the upfront surgery, and the other 51 case goes to neoadjuvant chemotherapy, and this case goes to the firstly selected infusion chemo, and the other case goes to the infusion chemo combined with embolization. And so in the result, so you can see here that and 5 case goes to the after infusion chemo, the 5 case goes to resection, and the 2 case goes to resection, and after the adjuvant treatment, in the result, the 2 case goes to downstage and referred to surgical department. So finally, total 9 case is referred to the hepatic resection. Let me see the 1 case. So you can see here that this patient was 74 years old when diagnosed with a primary hepatocellular carcinoma. Primary hepatic carcinoma is located in a whole left lobe with complication is hepatitis virus C. And the tumor developed the whole left lobe with portal vein thrombosis, progressed to the portal vein trunk. Because liver function was maintained and the enduring catheter was placed and the chemotherapy was initiated with selected embolization. I mean that embolized with the area of portal vein thrombosis because we can fortunately selected the feeding artery of portal vein thrombosis, and then the tumor marker is a decline, and also you can see here that the left lobe tumor and the portal vein regressed. So I referred to the surgical department, and so finally he resected with a left lobe with a left portal vein trunk. So this case is survived more than 5 years. So this is downstaging and conversion therapy. So let me see the survival rate of patients who were able to combat with infusion chemotherapy. In the left figure, the prognosis of 4 case, it means that upfront surgery 4 case is not good. So the recurrence occurred soon after resection, and the 1-year survival rate was less than 50%. In contrast, in the right figure, you can see here that the total case is not so good. However, you can see here that downstage and conversion therapy received 9 case is a very good prognosis. It is natural because the chemo drug is effective and hepatic resection is with a good surgeon. So, but this selection is very important to because these patients the prognosis is very poor, and how to select that a good prognosis patient is very important issue to the treatment selection. So, as you can see in this slide, an introduction of the conversion therapy is an important strategy for prolongation of survival for advanced HCC. So, in 1985, the TS, so the transcatheter arterial chemoembolization was introduced in Japan in 1985, and we started the infusion chemo using an enduring catheter in 1990s. However, there is no treatment advancement, and during the nearly 20 years, we use the embolization and infusion chemo or systemic chemo or like that. But you can see here that in 2007, a new drug, a molecular targeting drug, you know that sorafenib appeared. So the treatment policy is changed. And in 2017, and you know that the lenvatinib, more purified antivascular endothelial growth factor drug, is introduced, and so we use the combination of lenvatinib and combined with interventional radiology technique with embolization or so. But most important is from 2021, so the new immunotherapy drug, atezolizumab and bevacizumab was introduced, and so another drug, new drug, durvalumab and tremelimumab is introduced in 2022, and this year in Japan we can use the new drug of nivolumab and ipilimumab. So this is a famous report published in the New England Journal of Medicine in 2020. Since then, the treatment has been introduced in many countries, and its therapeutic outcome have been confirmed, bringing about a paradigm shift in the treatment of advanced hepatocellular carcinoma. We have also introduced the atezolizumab and bevacizumab to the treatment of advanced hepatocellular carcinoma and reported their effectiveness in Hepatology International. The title is The Benefit of Conversion Therapy. The conversion therapy for patients with unresectable HCC receiving atezolizumab, bevacizumab, using a new concept, established oncological concept of resectability criteria in Japan. And this report is a real-world study, and my colleague, Dr. Shimose, and his colleague who retrospectively collaborated and analyzed the treatment and the outcomes at the major hospitals across Japan. In the past, I will introduce the newly proposed criteria for liver resection for hepatic carcinoma by the Japanese expert consensus. The novelty of this classification in the proposal of borderline resectable, so you can see here that the borderline resectable divided into the BR1 and the BR2. And so you can see here that the BR1 is a tumor condition in which resection alone generally results in a poor prognosis, but resection as a part of multidisciplinary treatment may be expected to improve the prognosis. And BR2 is, there is insufficient evidence that resection improves the prognosis, and the suitability of resection should be carefully considered with the context of multidisciplinary treatment. So now I explain the result of our study. We collected the data from 631 patients with hepatocellular carcinoma treated with atezolizumab, bevacizumab, and of these, 166 cases downstage, and so referred to the further treatment. So you can see here that the treatment result. So before the treatment, about 25 cases is a BR1 and the other case is BR2. After treatment, so you can see here that among 166 cases, the 28 cases are resectable. So I mean downstaging go to resectable. And so during BR2, so you can see here that the 52 cases are downstage goes to BR1, and 49 cases are resectable downstage. So you can see here this case. So this case was treated with atezolizumab, bevacizumab, was able to undergoing conversion resection after downstaging at the time of diagnosis. The tumor was 13 in diameter and has no prior treatment. After immunotherapy, the tumor marker rose temporarily, but then declined, and the tumor necrosis of main tumor depicted. So referred to surgical department, and so he achieved the complete remission. Then let me summarize the downstage and referred to conversion. And so you can see here that among them, 20 cases of the downstage. However, because of the comorbidity and the age and the liver function, the only 25%, I mean that the 34 case is referred to conversion therapy. So we also analyze the factor analysis. So you can see here that the younger age and the stage is the BR1, more smaller one, and the good liver function is easy to refer to conversion therapy. So this is a summary of conversion therapy. And now, oh, I'm sorry. So now, from now, I compare the result of conversion, the factor of conversion therapy, comparing with hepatic resection and RFA. This is a conversion therapy, is near to the complete remission. So you can see here that the 14 case is a surgery, referred to surgery, and the 20 case is goes to conversion, RFA. So result is very simple. So you can see here that if you convert it to refer to surgical department, the result is better than RFA. So, and if you downstage in the liver tumor, firstly you consult it with the surgical department, and if they cannot, so other curative treatment should be selected. So, in conclusion, the emerging of new immunotherapy has brought about a paradigm shift in the treatment of advanced liver cancer by managing the treatment, such as immunotherapy and other interventional technique with a multidisciplinary team, and appropriate adding the conversion therapy, we can improve the patient outcome and even achieve the cures. So Oldman says, and if you on the board, and if you have two captains, sometimes both run up on the mountain. So in a multidisciplinary team, the moderator or captain is the most important. Thank you very much.